Good morning. Welcome to our event, Forensic Nursing, the Healthcare Response to Violence. This event is occurring as part of the 2025 Victims and Survivors of Crime Week in Canada. I'd like to gratefully acknowledge the funding provided by the Department of Justice Canada for us to host this event, as well as the support of the University of Fraser Valley's Peace and Reconciliation Center. So my name is Dr. Amanda McCormick. I'm an associate professor in the School of Criminology and Criminal Justice here at the University. I'm also the commitment leader for the Peace and Reconciliation Center's community of practice on reducing domestic violence. Collaborate to identify and to address issues related to partner violence and other forms of gender-based violence in our community. It is my honor to welcome you here today to the University of the Fraser Valley. UFV is located on the traditional and unceded territory of the Stalo Nation, where we are gathering here in person today in Abbotsford. I'd like to acknowledge that we are territories of the Sumas and the Matsqui. We are grateful for the opportunity to live and to work on these. Please take a moment to consider and appreciate the traditional lands from where you are joining us today. If you're joining. So just a few things, there we go. Just a few things before we begin with the presentations for today. Just a couple of housekeeping items to address with you. Please note this event is being recorded. We will be posting the recordings to the Peace and Reconciliation Center website next week once we finish compiling and editing the recording. I will be emailing out a link to all registered guests, so you will be able to access the recording. Please note, obviously, our topic today is a heavy one, as we discuss the role of forensic nurse examiners in providing a healthcare response. We won't be discussing any individual cases or experiences of violence today, but please note that the subject matter may still be distressing, traumatizing for some. So please do feel free to step away if you need to take a few moments, sit outside or step away from your computer. We have a guy here as well. You might be able to pet the dog. We have resources as well that we can connect you with if you'd like to talk further to somebody. Today's event is a hybrid event, so we do have many people here in the room. Thank you for joining us today on campus. And we have a large group of online attendees as well, participating from many in BC, but also some people joining Canada. So thank you so much for joining. For those that are joining us in person, just wanted to quickly make note that the washrooms are located just across the hallway from where we are here, so feel free to step out. We will take a short break midway through, but feel free just to step away if you need to. If you're here in person and you didn't register or check in at the registration table, please make sure to do so at the back there near the audio-visual team. They're waving at you right now. So we do have a sold-out room. We would like to make sure we have space for everybody that did register in advance. And they also have some handouts that they're giving to you. And please, if you have a minute as well, feel free to check out the Purple Lights Nights table at the back here. Sue and Lisa here representing our Purple Lights Nights committee, where we raise awareness about domestic violence in our communities. And so they have lots of handouts that they would be happy to give out to everybody in the room. For those who are attending online, this is a webinar, so your cameras and your video have both been disabled, although the chat is very heavily in use this morning. You'll be able to hear and see the presenters, obviously, and you will be given opportunity to ask questions through the question and answer module. And so I have a couple of my research students here, Bethany and Amrit, are helping out monitoring the Teams chat. So please pop in questions there if you have any. So there will be a few different ways then to ask questions from the audience. We are going to hold questions to the end of each presenter's talk, just so we have time to get through the content. For those attending in person, we have microphones available throughout the room. So if you are comfortable asking your question, just pop your hand up and one of the students will run the microphone over to you so you can ask your question. Please do use the microphone, even if you feel that your voice really does carry. We do have people attending via webinar and microphone to make sure that everybody can hear us. You'll also see on the table that there is a little container there with some pens and pencils and cue cards, and then there's a little green dish in front of you as well. Feel free just to write down any questions that you have and pop the card into the little green dish on the table. Again, the students will be running around the room, picking up those little green dishes. Caitlin, I think you might be helping us with that. Thank you. And so we can read out the question for you if you're more comfortable having us ask the question on your behalf. You can also, even if you're here in person, log in to the webinar. I think we've solved the issues with the link. So you can log into the webinar even if you're sitting here today and pop your question into the Q&A there. So lots of ways to ask questions, and we do encourage you to ask as many questions as you have because you have the experts here in the room with you today. So please take advantage and ask those important questions that you've always wanted to ask. So we should have about 5 to 10 minutes after each presenter for some questions, and then some time at the end of the day before we wrap up as well. We also have some questions we're asking of you as the audience member. You've probably heard now, I've mentioned it several times, and the students have as well. We are collecting some survey data from registered attendees, both prior to as well as after the event that we're holding today. And we're doing this to identify whether we've met your needs and your objectives in attending the event today, as well as to measure changes in knowledge about the forensic nursing service in British Columbia. And we're going to be taking this information, compiling it, and reporting it back to the Department of Justice, who funded this event. The pre-event survey can be completed several ways. If you're online, Amrit or Bethany can pop the link into the chat for the pre-event survey. I've also emailed it to you several times. If you'd like to participate, please just click on the link. It takes just a couple of minutes to read over the information sheet and then to fill out the questions. It's voluntary and anonymous, so you're not required to do that. But again, any feedback you can give us will be really helpful. If you're in the room here as well, we also have some handout copies that you were given when you checked in at the front desk. And so included in that is the information sheet about your rights as a participant in a research study. We have the pre-event survey here. You can just fill it out and give it to the students at that table in the back. And then there's also a couple of other advertisements for other research that we will go through in just a moment. So please don't put any identifying information on that pre-event survey. If you'd like to fill it out, please take a minute to do so now before you start hearing all of the content. We're also going to have a post-event survey that we will share a little bit later towards the end of the event. Okay, in addition to that, you'll also see online, we'll share the link as well, and then you have in your booklets a couple of other research studies that we're doing and we would like to share out with you and have you share with your networks. And so one of the studies that we are doing is a stakeholder survey where we are measuring awareness about the forensic nursing service specifically in the Fraser Valley, so Abbotsford, Chilliwack, Hope, Agassiz, those communities. We're really hoping to hear from stakeholders, which includes community members, as well as people who work in the Fraser Valley. What do they know about the forensic nursing service? Have they tried to access the forensic nursing service? What feedback do they have? So this, again, voluntary and anonymous. It takes about 10 minutes to complete. There's a little bit of overlap with the survey that we're doing for this event as well, but this one is more specifically for people in the Fraser Valley for us to learn about where those gaps in awareness are that could inform any sort of future outreach campaigns that we'll be doing. You can also scan the QR codes there and in your handouts, but we'd be very happy if you could please disseminate that. So we're also doing a survey where we are seeking feedback from victims survivors in the province of British Columbia, and we are truly hoping to hear from people all throughout BC, including those more remote and rural communities. We are collecting feedback from people who have experienced intimate partner violence or sexual violence in the past couple of years, so since January 2023. What we are seeking to do with this study is to get a sense of the levels of violence people are experiencing and then whether they've attempted to access a medical forensic exam, regardless of where they are in the province. We're trying to get a sense of what people know about medical forensic exams and get a sense as well of those barriers to access. And that will, again, inform outreach efforts or potentially even our efforts to more fully develop the forensic service throughout the province of British Columbia. So this survey does require that you're 19 years of age and older, but again, we'd appreciate it if you could please share it with your networks as appropriate, as we are trying to hear from as many people as we can from across the province. All right, so based on these two studies, we have had these studies launched now for a few weeks, and so we have collected some preliminary data from both stakeholders as well as victim survivors. And I did just want to share a couple of those preliminary findings that we're seeing, because it really speaks to why we are holding this event today, why it's so important for us to get this information out to people. So I won't go into detail about those trends, because again, we are still collecting the data, but we are seeing some distressing trends coming in from the responses so far. We are hearing about some really severe forms of violence that are being experienced by survivors in British Columbia, yet less than 1 in 5 appear to be seeking out a medical forensic exam. So there are massive gaps then when it comes to the healthcare response to interpersonal violence. When we asked people to share with us some of the barriers to accessing medical forensic exams, unfortunately, many of the survivors that we're hearing from have told us that they are embarrassed about being a victim. They were worried that they would be blamed for what had happened to them, or they were worried that other people would find out about what had happened to them. No one should be embarrassed to be experiencing interpersonal violence. Statistics Canada data tells us that 44% of all women and girls in Canada who have ever been in an intimate relationship have experienced some form of intimate partner abuse, while around 4.7 million girls and women in Canada have experienced sexual assault. These numbers are even larger for some groups, including Indigenous people, Indigenous women in particular, people identifying as two-spirited or LGBTQ+, and people with disabilities as well, much higher rates of these forms of violence. These are not uncommon, unfortunately. And in fact, earlier this year, our Premier in BC, Premier David Eby, declared gender-based violence to be an epidemic. I repeat, no one should be embarrassed about being a survivor of interpersonal violence. It's important to know, and you will hear plenty about this today, that forensic nurse examiners are trained to perform trauma-informed exams. But what many people don't appear to know is that you, as the patient, have choice. You can choose whether or not you want to seek a medical forensic exam following an act of violence. You can even choose whether that exam is simply a medical one, checking you out to make sure that you're okay, or that forensic component is added, where the forensic nurse examiner will conduct a more detailed examination of your body from head to toe. Even then, within that, you still have a choice. If there's somewhere you're not comfortable with the forensic nurse examiner looking or touching, you have that choice to say no. Forensic nurse examiners are non-judgmental. They have seen it all. Someone's sexual orientation, their gender identity, their race, their ethnicity, none of this is of concern to the forensic nurse examiner. Speaking of choice, another concerning trend that we've seen emerging in the data is that a majority of the victim survivors that we've heard from have so far believed that they were required to report their victimization to the police in order to access a medical forensic exam. This is simply not true. As you'll hear today, patients have choice in the matter. No one is forced to receive a forensic exam, and no one is forced to report their victimization to the police in order to access a medical forensic exam. People who access a forensic exam can choose to have that information reported to the police, but they can also choose to have that information stored. Maybe they're not ready to report now, maybe they never will report to the police. That is their choice. Okay, so please just know that there are some myths around access to medical forensic exams that we are trying to address with the event today. Interestingly, one trend we have not seen in the data was a lack of awareness about the forensic nursing service. Both victim survivors, the community members we're hearing from, service providers that are participating in our surveys, they're all familiar with this concept of forensic nurse examiners and medical forensic exams. However, we are hearing uncertainty about what happens if you seek a medical forensic exam. We're hearing that people don't necessarily know where to go to get one, or when they can go to get a forensic exam, or who can go to get a medical forensic exam. They don't understand exactly what it is that forensic nurse examiners do, and that's why we're here today. So the objective of today's events are to address some of these gaps in knowledge and the myths that people hold about forensic nurse examiners. We know forensic nurse examiners play a vital role in providing a healthcare response to violence, providing care that is holistic, trauma-informed, and patient-centered. They can address risks, they can prescribe medication, they can connect patients with needed supports at the community level. Maybe that's emergency housing, maybe that's victim services to work with. They can connect them to ongoing care as well, whether they have injuries from like a brain injury or if they've experienced strangulation. So they can connect people to the various resources that are available. So today you're going to hear about the importance of trauma-informed approaches. You're going to learn about who can access medical forensic exams in BC and where and how these can be accessed. And you'll learn about the strangulation clinic and the outpatient services for people who've experienced violence through the one-of-a-kind Embrace Clinic. We'll have a presentation on that today as well. And so with that, I'd just like to pause quickly just to check if there's any questions before we introduce the first speaker today, Angela Heino. Okay, so I'd like to introduce then our first speaker, Angela Heino, who's going to be talking today about trauma and violence-informed care. Angela, she or her pronouns, works as nursing faculty at BCIT and as the decolonizing lead in the BSN program under the guidance of the Indigenous Initiatives and Partnerships Office. Angela has been a registered nurse for over 2 decades and has over a decade of training and experience as an educator in both healthcare and post-secondary settings. She's completed additional extensive training in forensic sciences and works as a subject matter expert and consultant on projects covering a wide variety of topics. The focus of her graduate work was the exploration of women's pain experiences in relation to pressing health concerns and the need to create trauma and violence informed and culturally safer environments for clients, families, and healthcare providers alike. She's a parent to two beautiful humans and a guardian to two dogs and one cat, all adopted from the SPCA. Please join me in welcoming Angela.
Good morning, everyone. It's a pleasure to be here this morning, and thank you for the lovely introduction. I'm honored to have been asked to share a little bit about my role at BCIT and the work that I do. It's work that I'm very passionate about, and I continue to learn and unlearn every single day. So thank you, Amanda, for your land acknowledgement. And I also wanted to add that I too wanted to acknowledge the traditional and unceded territories of the Stolo peoples here at the University of the Fraser Valley and the broader Fraser Valley region. I am myself of mixed Scandinavian, European, and French Canadian ancestry, and I'm grateful and honored to be here today. As a healthcare provider, I also acknowledge that we have a collective responsibility to create culturally safer and educational care and educational environments. And I'm committed to my own truth and reconciliation journey, a journey that I've been on since I did my graduate school degree at UBC many years ago, and to my own learning and unlearning. A little hard to see the slide. Okay, so I'm here to share a little bit about what do I do at BCIT? What is the role of a decolonizing lead? So that's a great question. So I'm not going to read all the content on this slide, but over the last 2 years, I've been given the opportunity to work in a 0.8 full-time equivalent capacity as a decolonizing lead for the School of Nursing at BCIT. And in a 0.2 capacity, I also work in simulation and with the experiential learning team. So as a decolonizing lead, my understanding of this role as it has continued to evolve, just like I said, I keep learning every day and no 2 days are the same. But it is both, it's twofold. Is number one, to address the impacts of colonialism and of colonization on the ways that we understand the world, in particular health and wellness. And because nursing has traditionally been based or founded on a very Western or Eurocentric model of understanding the world, decolonization seeks to look beyond these and not only looking at the value of these knowledge systems, but also bringing in Indigenous perspectives and worldviews, because doing so benefits all of us. So in this work, it requires me to constantly examine my own positionality, my privilege as well, and also invites me to learn from Indigenous elders and partners and people with lived experience about their experiences of navigating the healthcare system and their experiences of the healthcare system. As many of you might know, in 2020, the In Plain Sight report was published, and that report detailed in great detailed, very exhaustively, the experiences of Indigenous peoples in BC healthcare systems and of Indigenous healthcare providers in their experiences of racism as clinicians as well. And so this report was very pivotal for us in post-secondary environments and looking at how do we then prepare future healthcare providers to practice in a culturally safe, trauma and violence informed way based on what we're hearing directly from Indigenous peoples themselves. And so this report has really helped to guide some of the work that I do, but I also am guided by multiple other documents and reports, as well as books and articles written by a wide variety of scholars. Sorry. Okay. So as Canadians, Truth and Reconciliation through the TRC recommendations that came out and the calls to action requires that this is all of our work to do. And for nursing in particular and physicians as well, there have been standards created to which we are held to account for addressing racism and in healthcare settings. And so for the work that I do, uh, I'm guided by all of these documents in trying to understand how do I then bring this into the nursing curriculum and helping to shape the nurses of tomorrow. And now we're seeing more and more than an alignment with healthcare authorities that nurses, when they're poised to enter practice, this was taken from a new graduate job description for the PHSA. So it was asked that candidates who are applying for a position to work in the PHSA have detailed knowledge of truth and reconciliation and have considered the impacts of that on them and on their practice, and that they have knowledge and familiarity with some of the key foundational documents that we also explore in our nursing program. So this might mean the UNDRIP and DRIPA legislation. It might mean the In Plain Sight report, the BCCNM standard of practice on Indigenous cultural safety, cultural humility, and anti-racism, as well as a variety of other documents. So this is all documents that nursing students in the BSN program will be asked to read and reflect on prior to them graduating from our program and entering the nursing practice, no matter where they end up practicing. So structural violence, part of my role is looking at individual responses to violence. And I'm very, very fortunate to have learned from some people in this room. And I feel like I'm still very new on this journey and learning about forensic nursing responses. But when I was talking to Adrienne about this and my own role within forensic nursing, I think what I see is my understanding about the need to address systemic violence. So we need to address interpersonal violence. That is absolutely crucial and important. But what I'm hearing more and more from the media and from people who are involved in this work is the systemic nature of violence and the ongoing harms that this causes. And this violence can occur in healthcare environments. It can occur in legal environments. It can occur in governmental environments. And so these are deeply embedded systems that are very difficult to change. But just because they're difficult to change doesn't mean we should lose hope. And I think there's so much to be hopeful about. There are a lot of people who are doing this work who are trying to advance the need to recognize how systemic violence is pernicious and deeply harmful to many people. And so we know that systemic violence or structural violence is a widespread, urgent public health issue. And we see that play out in the ways that gender-based violence continues to be an epidemic in 2025 when we've been having these conversations for decades. And so I think the time is more urgent than ever to really look at how is systemic violence continuing to be perpetuated and how do we address that and how do we steer the system in a different direction. And I think that nurses in particular, there may have been previously avoidance of people going into healthcare environments. And certainly my eyes were opened as a graduate student at UBC when I was fortunate to listen to and learn from Indigenous women living on the downtown east side. At that point in my life and in my career, I had gone through the public health system where I did not learn about residential schools. I did not learn about the history of Canada with Indigenous peoples other than it was relatively peaceful and Hudson's Bay was a good thing. But beyond that, I didn't know anything of what had happened because I had not received that education. And so when I was at UBC and in classes taught by professors who were deeply embedded in this work, my eyes were gradually opened to what was happening around me. And so when I listened to women living on the downtown east side who were explaining or detailing to me their experiences of going to local emergency departments and how harmful they felt that experience was to them because they felt judged and labeled and stigmatized, I had had no idea, and I was very awakened suddenly to my own privilege because that was not my reality. I did not have to worry about going to an emergency department and feeling that way because of my privilege. And so I really started to think about the role of nursing and the role of medicine, the role of all healthcare professions, and ensuring that we are taking care of people in a very non-judgmental way. And I think forensic nursing has been at the forefront of that in providing that really culturally safe, consent-driven experience for people who've experienced violence. Okay, so trauma and violence informed care. So what is that? Because we've heard about trauma informed care, and this is trauma informed care is absolutely vital and important part of the care that survivors of violence receive. But I was fortunate to learn about TVIC as a graduate student, and it really helped me to understand violence from a zoomed out lens in a much broader way. So I just wanted to share with you in the brief time that I have with you today. And I was just going to say, Amanda, please wave at me when my time is up because I want to make sure I'm respectful of other people's time because I could go on about this for hours. um, but I wanted to share just briefly with you what is TVIC and what did that can that look like in practice? What does that mean for people who've experienced violence? And what does it mean for providers? So, briefly, I just wanted to touch on trauma, and I wanted to read a definition of trauma. That is to say that there's no universally agreed upon definition of what trauma is. I think more than ever, there's more and more conversations. There's research happening about what is trauma and what are its impacts on the people who experience it. And I'll touch on this just briefly, but I wanted to share a definition with you. And I'm just going to read it here. It says trauma refers to experiences or events that, by definition, are out of the ordinary in terms of their overwhelming nature. They are more than merely stressful, they are also shocking, terrifying, and devastating to the victim, resulting in profoundly upsetting feelings of terror, shame, helplessness, and powerlessness. A traumatic event involves a single experience or enduring and repeated events that overwhelm the individual's ability to cope or integrate the ideas and emotions involved in that experience. So again, trauma is a highly personal and subjective experience. Different people will experience trauma differently. And so I think when we're trying to work with people who've experienced trauma, we have to hold space for that ambiguity and the nuance and understanding that every person will experience trauma slightly differently. And again, here, there's no universally agreed upon definition of the different types of trauma, but these different categories are ones that I encountered in a book on trauma and violence informed care, edited by Watson and Varco. So there might be situational trauma, so trauma that occurs out of a situation, for example, like an assault. It may be collective or historical. So we have heard about, particularly in Canada, the impacts of the residential school system caused collective and historical trauma. This can also occur in times of conflict. Mass casualty events, for example, will fall into this category as well. Interpersonal, so we see this in the context of intimate partner violence and family violence. Complex trauma, so people who've experienced trauma may experience different kinds of trauma throughout the lifespan. And we know that uh, there's a dose response aspect to trauma in that the more trauma that a person experiences, the more cumulative the impacts tend to be, and this can occur throughout the lifespan. And then vicarious trauma or secondary trauma, we've heard that can happen when people who are working with survivors of violence may also themselves experience that vicarious trauma. And we've heard about this also with first responders. And this is something that is still very much being looked at and researched so that we can support people who are also supporting other people who have experienced violence themselves. So the prevalence of trauma is is high. We know that 3 out of 4 people may experience some kind of traumatic event in their lifetime. Sorry, this is hard to see. I don't have the writing in front of me. I might just. Oh, sure. Or I can pick up the mic, maybe. Is that okay? I don't want to. There we go. Sorry, I'm just going to turn to read this a little bit. But in 2019, 80% of people who had experienced IPV did not report it to the police. And I think that aligns very much with what Amanda shared this morning. 44% of women and girls who have ever been in an intimate partner relationship report experiencing some kind of psychological, physical, or sexual abuse. And this is from a Government of Canada fact sheet that was updated in 2025. Women tend to experience more severe forms of IPV, leading to also more severe injury and more negative health outcomes. Indigenous women face unique barriers to reporting experiences of violent victimization due to ongoing systemic racism and the negative impacts of colonialism. In 2021, the homicide rates of Indigenous victims was more than 3 times that of gender-related homicides of non-Indigenous persons, and gender-related homicide is 2.5 times higher in rural areas compared to urban areas. So with the Red Dress Day that just passed, I think there was again a call for all of us Canadians to understand the particularly unique context of Indigenous women and the violence that they continue to experience as a result of racism and colonialism. So the impacts of trauma can be several-fold, and again, this is not meant to be an exhaustive list. Different people experience trauma differently, but it can range from the re-experiencing of that trauma in various ways and avoiding triggers that may cause distressing symptoms to increased arousal, in impacts on hypervigilance, attention, memory, and focus, as well as negative mood changes. And this can affect mood. And again, trauma affects almost every organ system in the human body. So the forensic nursing context, this slide was informed by conversations that I had with Adrian, but medical forensic exam is not considered mandatory healthcare, and it's an exam that is driven by the informed consent with a patient, and is meant, the information in medical forensic examination is meant for outside healthcare. So a patient is always needing to consent for this information to be shared. And this differs a little bit sometimes from what we see in the broader healthcare system, where I think the forensic nursing exam is really about being patient-centered and having the patient be informed and consenting to every aspect of the exam and then what happens after. So the focus is on control, autonomy, dignity, compassionate care, which is restorative and healing-centered, regardless of the legal outcomes. So this is where the trauma and violence-informed care aspect comes in, is that the forensic nurse examiner is offering choice, collaboration, and building trust with that patient. So why the V? The V is really about drawing attention to the broader societal impacts of violence. So we're moving beyond the individual person and looking at the ways that systems can perpetuate violence against people and trying to offer, again, a way to restore some power and control to the person who's experienced that violence. So it reframes responses from, what's wrong with you to what's happened to you, right? Sometimes there's been historically a tendency to pathologize a trauma response or to look at it as something's wrong with you, as something's broken, when in fact, these responses are normal responses to deeply abnormal events. So in trauma and violence informed care, the responsibility for creating culturally safer and responsive environments rests with the provider and with the system in which the care is provided. It's a universal approach, so it doesn't require providers to ask about trauma, but it rather requires providers to understand that anyone that they are working with or seeing, and that can include colleagues as well as patients, may have experienced violence in their life, and to hold space for that. And it includes explicit attention to structural and systemic violence. Because again, what we're learning as nurses is that it is our collective responsibility to speak up and to advocate and to address structural violence when we see it happening. I started practicing at a time where, when I witnessed events in clinical practice that were deeply concerning, there was a tendency to not address that, to sort of look the other way. And now we're being held to account to intervene, to address, to advocate when it's appropriate to do so, and to make sure that we're putting our clients' needs first. All right, so I've already kind of gone over this, but it's really about also, I think, I want to highlight on this slide is building on a person's existing strength and skills. I think that often medicine and nursing is based on a sort of deficits model, a diagnosis model, rather than looking at how strong and resilient people are and building on that and validating people's worth. Here, I just wanted to point out that implicit bias is something that we all have. We all operate with implicit bias. It's how our brain sort of functions efficiently. Our brain takes shortcuts every day because we're inundated with information and we have to make decisions. And in busy healthcare environments, this can cause sometimes that we make judgments or we make decisions that might not be fully thought about because we're operating under very real constraints. So again, having implicit bias is not in itself a negative thing. It's just something that as healthcare providers we need to be aware of. And healthcare providers have the same levels of implicit bias as the rest of the population. And some of the communication strategies that we encourage people to have, our nursing students to have as they approach care is multifold, but it really is to allow, when we're walking into a room with a patient, is always to be aware of how we're coming across, because our feelings, our mood, our level of confidence, our stress seeps through our pores, even when we think we might be hiding it from other people. And I certainly have had the experience of being a healthcare recipient and feeling the difference between someone who's really present versus someone who's trying to act like they're present. And I know what that's like. And so it's something that I very much try to remember when I'm working with people. We want to consider not only what we're saying, but how we're saying it, that we're there to, not to judge, but to understand, and really about exploring using open-ended questions. Am I doing okay for time? I'm almost done. Okay, sounds great. Thank you. Being comfortable with silence is something I've also learned the hard way, is that we don't always have to fill every moment. And sometimes when we allow people the time to think about what they want to say and holding space for that, it really allows that connection and that trust. And offering a sincere apology when we make a mistake. And I say when because in the work that I do as a decolonizing lead, making mistakes is part of the learning and unlearning that I need to do as someone who has been relatively newer to this space. And I think that there's a certain amount of humility that needs to come with that, is that recognizing that I am not an expert. I have some levels of expertise in certain very specific things, but I don't consider myself to be an expert, certainly not on decolonizing, and I am learning all the time. Keeping an open mind is very important, practicing intellectual and academic humility. And for me, that's really about understanding that I don't understand the world as it is, I understand it as I am, and that's the quote by Anais Nin, but it's about recognizing the constraints of our own knowledge and knowledge systems and being open to what other people think. And healthy debate is part of the post-secondary environment as well. So conveying unconditional positive regard can be very, very powerful. And there was one woman that I spoke to during my master's work that told me that she remembers an encounter with a healthcare provider in an emergency department in the Lower Mainland, and how that person, simply by looking at them and acknowledging that they had come to the emergency department, that they were here, and wow, that was amazing. That made all the difference to her and stayed with her years after that interaction. So it doesn't take a lot of extra time to really make sure that we're validating people's worth and how far they've come just to be where they are. And then it's also about caring for the self, caring for ourselves when we've experienced violence or trauma, caring for ourselves when we work with people who have been, who have experienced violence and trauma. So that idea of practicing self-compassion was something I didn't learn until much later in my career. But now that I've learned about it, it makes a lot of sense. And it's something that I have to remember every day. Sharing decision making and collaboration, making sure that we're not alone. There are people who can support us, colleagues, people with lived experience, supporting one another, filling up our own tanks and making sure that we pause and reflect and rest. So some of the key messages that I just wanted to leave you with today include that the effects of trauma and violence are cumulative across the lifespan. Many social and structural factors, including policies and practices that we see in systems now, can contribute to ongoing harm within healthcare and educational systems. Common actions for healthcare providers and educators can be re-traumatizing, potentially for people who've experienced trauma and violence. And an environment that is that is safe for the most traumatized person will be safe for all people's healthcare providers, educators, and learners alike. Demonstrating non-judgmental and anti-discriminatory and non-stigmatizing attitudes is a fundamental aspect of our roles. We want to express compassion and positive regard while promoting safe decisions and behaviors, cultivating the ability to examine with humility our own roles and actions in upholding systems that might cause harm, and showing a commitment to structural competency, including lifelong learning, unlearning, and advocacy. I just wanted to share here, there are a number of resources and learning opportunities for people through the EQUIP website. So EQUIP is a nurse-led research office at UBC, and there are a whole list of resources that anyone can access for free, and some of them are listed here. References and any comments or questions? Thank you. Any questions online or the room? Or comments too? That's great. Okay.
Okay, so we do have a question from online. So in your role, how are you approaching the preparation of forensic nurses, the majority of whom are white women, to provide culturally safe, trauma-informed care to Black, Indigenous, and other women of color? Given the disproportionate rates of violence these communities face, how do you ensure care is not only clinically effective, but also culturally grounded and equity-driven? It's a big question.
Yeah, it's a huge question, and thank you so much for asking it. I personally am involved in the BSN program. So this is the general kind of preparation for nurses. So forensic nursing, as we know, and I think it's going to be potentially designated as a specialty by the CNA. It's in the process, I think. So forensic nurses undergo specialty training, also offered through BCIT. And so I don't feel that I can answer that particular question, but I think it really starts in the foundational program. And if nurses go on to train in forensics, this is something that they would continue to seek out. This training, this preparation as they progress. But I think for myself in my role at BCIT, it's really about learning from and prioritizing the voices that have been traditionally not prioritized and not centered in the way that it should. I think I agree that nursing has been, and Blythe Bell out of University of Victoria has written extensively about how whiteness has been centered in nursing and how this is something that we're trying to deconstruct and unpack because of the harms on people who from equity-seeking communities. So it's a big question, and I don't have a simple answer, but I wanted to acknowledge that there is a lot of complexity. It's an ongoing effort at BCIT and the BSN program to look at the curriculum and to try to bring in the voices that haven't been prioritized and to provide specific scholarly work and strategies that they can take into their practice. So just to give you an example, just briefly, I'm currently doing some simulation training, and I took a course through COSN where I created a storyboard for a anti-racism simulation. So it would be, and it's based on the tool that was circulated at the COSN conference, so the Canadian Association of Schools of Nursing conference last year by Dr. Holly Graham at the University of Saskatchewan, called CPR Racism. So it's called CPR Racism because Dr. Graham wanted to alert people to the fact that racism can be life-threatening. And we've seen in cases of Brian Sinclair and Joyce Echaquan, who died in Canadian hospital environments, that racism can kill people. And so using the tool by Dr. Holly Graham, I'm in the process of designing a simulation that'll invite nursing students to use that tool to address racism that they see happening in a simulated healthcare environment. So I think it starts with having opportunities for learners to have these difficult conversations in nursing school as opposed to when they're out in practice and they never had that conversation. Thank you for the question.
One more comment that we wanted to share quickly, Amrit.
Yeah, another comment here. As a First Nations RN who was raised in textbook social detriments of health, I often wonder how lived experience compares to trauma-informed care that is taught in a safe classroom environment.
That's a great comment. Angela, I don't know if you wanted to take that on and just mention a quick response. Thank you for sharing that comment.
Yeah, thank you. That's a great question, a great observation. I think in my own learning, I've come to understand that lived experience has not been valued in the way that it should be. And I think there's an effort, a collective effort to ensure that we're trying to include more diverse perspectives and worldviews into the classroom environment, but also into the curriculum itself. I think that nursing and medicine, as I've mentioned before, has been very centered in white Eurocentric knowledge systems. And I think that there is a realization that this can be very constraining and limiting. And we know that racism is also a social determinant of health. It deeply impacts the health and options for people who are not white. And so we have to acknowledge that as a profession, we need to do better, whether it's training nurses and medical students to understand different bodies and different ways of assessing injury, for example, bruising on Black skin, and also incorporating various perspectives and worldviews because we all benefit from that.